بسم الله الرحمن الرحيم. السلام عليكم جميعا. Good evening, good morning, and good afternoon, ladies and gentlemen, wherever you are in the world. I welcome you all to this 11th session on ASPAR World Forum on Future of the Future. First of all, let me introduce myself. I'm Dr. Maha Al-Munif. I am a clinician and a professor of pediatric infectious disease and epidemiology in King Saud bin Abdul Aziz University for Health Sciences, and I'm the founder of the National Family Safety Program on Social Protection. Before I start, I would like to really to thank the ASPAR Forum for organizing such a great summit and bringing experts from all over the world to discuss the future especially during this challenging time of the COVID pandemic. Our session tonight, the 11th session, is titled Health 2050, Human-Driven Health. It is a very important session because it brings leaders from healthcare system, from the digital health, from academic institution, from artificial intelligence, and from businesses in order to discuss the vital role of technology and digital health in healthcare sectors in general now and in the future. Without further delay, I know we are a little bit short on time. I have 4 distinguished speakers. Each one will have about 7 to 10 minutes to tell us about the subject on the role of technology in health. And this will give us really an ample time at the end to have at least 1 or 2 questions to each speaker and discussion. Without any delay, let me introduce my first speaker is Dr. Nazih Al-Uthmani. Dr. Nazih is an associate professor of electrical and computer engineering in King Abdulaziz University in Jeddah. He is also a medical device expert, and also he got 2 patents in medical devices. Dr. Nazih is going to talk to us today about big data analysis and genetics, the future of personalized medicine, and in Arabic, معالجة البيانات الضخمة للجينات مستقبل العلاج الشخصي. Dr. Nazih, the floor is yours, and you have about 7 to 10 minutes maximum to tell us the important point on the big data analysis and genetics. تفضل دكتور نزيه. Dr. Nazih, the microphone is your microphone maybe is in mute.
It should be working.
Yes, it's working now. Go ahead.
Is it working now? Can you hear me?
Yes, we do.
طيب تمام. Thank you. So I'll be talking about genes. I will start basically what is a gene. If we go from the smallest unit to the largest unit, genes are small elements within DNAs that are within chromosomes, that exist within nucleus, that is within a cell. Cells together form tissues, tissues together form organs, and organs together form human beings. So a very small element within human bodies. And these elements, I'm sure most of you know, that these elements, the way these genes are arranged, may indicate your and determine your skin color, eye color, hair color, what allergies you may have, mastering some artistic skills like your vocal sounds, nice ability to have pitch, high tones and high pitch, sleeping habits, balding, even if you become bald when you grow older, curly hairs, weight, some chronic diseases, autism, cancer, and so many other things. So these genes are sort of like markers. Once you find certain genes, it may indicate, I say may indicate that certain behavior or certain human traits exist within you. Many people have tried to count how many chromosomes that we have. Some people say that we have from 50,000 to 300,000 base pairs of chromosomes. Now, genes and data. Now, DNA is made of usually is made of 4 chemical units, amino acids that are determined as A, T, G, and C. So people, when they do gene sequencing, they try to go to the DNA strand from the beginning to the end to find the sequence of these amino acids and how they are arranged. And the way they are arranged reflect the way you look, the way you act, the way you appear in general. So this is really significant big data. If you look around, if we said 300,000, 50,000 chromosomes, and you start tracing all of them, this is really big data. Now, this big data is very useful, and there are many people who are trying to make use of it. Now, the Human Genome Project started in 1990 and was completed actually in 2003. More than 2,800 researchers discovered 2,800 researchers worked and discovered that there are probably about 20,500 human genomes. They were from 20 institutions from 6 countries, and they managed to identify 20,000 human genes that exist within these countries. Now, what is next? Now, what they will try to do is to match these genes with human traits to identify, to detect genes that represent normal and abnormal behaviors, desirable and undesirable traits. If you know what are the genes that exist within your population and you start matching these genes with the traits, then you may identify the genes that are responsible for different things. E-health files will also enhance this, as we're going to see. Saudi Arabia has also started the Saudi Genome Project. There are 8 research centers and universities participating in these efforts, and the goal is to identify genes associated within the population within Saudi Arabia, to identify genes responsible for genetic diseases, warn against potential disease within children from parents, and find a roadmap for the genetics distribution in the kingdom, to identify new methods for diagnosis and treatment and prevention from disease. Now, if you know the genomes and you know the health traits and you have e-health records, we have 30 million people in Saudi Arabia. If we have e-health records that record their diseases and their pattern of disease and their pattern of healthy habits or unhealthy habits, or their vital signs as they grow and grow in age. You have these things and how they evolve with time, and you have their genomic sequences. Now you start matching. This is the future of the health. You start matching these health habits and development of health with the development within genes. And that at the spans of 65 years, you have huge data that could enable you to get and correlating the genomic sequences with the health habits of human beings. It will enable you to have a different perspective on health for the people and human beings. Why? Later on, you can start doing gene editing. Many methods do exist already for gene editing. Why do you want to do gene editing? You want to remove abnormal parts within the gene, within the DNA, and replace them with better parts. You want to remove undesirable habits with desirable habits. Note that I'm talking Health 2050. This is not yet very practical with human beings yet. We are not going, we haven't reached there, but we are heading in that direction. We will start develop drugs that will avoid the allergies that appear in your DNA. We will start even treating some of the chronic diseases by editing the genes directly. Now, sounds easy, sounds simple, and there are many methods that do exist in this issue. However, if we talk about mutation, mutation is a change in DNA, and gene editing is a mutation. The effect and the impact of this gene editing may take several years to appear. you never know, because mutation, any changes may lead to cancer and other severe illnesses. You might, nothing may appear in you, it may appear in your children and your siblings. So this is not a simple task, or not something that could be done as easy as I mentioned it. People need to ensure that the editing will not result to negative types of mutations that may harm the person in the future or harm their children and siblings. So for recommendations, there need to be ethical guidelines. The world is heading there. People are doing this. Genes are being sequenced, they are being stored, health habits are being stored, and they are being linked. And people are working on gene editing. This is a reality. It's done in plants. The CRISPR technique is for gene editing is very successful in plants, and it is happening already in plants. And I'm sure that within few years, people will start talking about doing it gradually in human beings. So there need to be ethical guidelines and regulations on genes, on gene editing specifically, and even on gene sequences. It shouldn't be something available for anybody to start doing it and storing this data. Privacy laws, because if people know the gene sequence of a person, they may give him or her a certain drug to modify the gene sequence without anybody discovering anything, and that person may harm him or herself. So it's really something very dangerous. And privacy laws need to be implemented to prevent sharing these gene sequences with the general public. Research funding, despite these cautious things, there is a potential and a good opportunity to treat diseases, handle many health issues through gene editing and gene personalized medicine. So research funding and capital development in human beings that are expert in this need to be established. And of course, linking big data analysts and artificial intelligence specialists with genomic researchers is also very helpful, because they start, when they start correlating these gene sequences with health habits and with other things on individual base, on personal base. So they have my gene sequencing, they know my habits, so they start correlating my habits with these sequences based on the previous knowledge that each gene represents a certain disease and a certain trait. So they will start knowing more information about me. They may predict my future illness. They may predict any future problem that may take place, and they may start introducing drugs and personal treatment designed personally for me, so that with the help of God, these things don't happen. Generally, we're talking health 2050, and I think this is going to be a very promising field in the future. And I look forward for the presentation of my other colleagues related to big data and AI.
Thank you very much, Dr. Nazih, first of all, for sticking on time and for really shedding a quick overview of the new technology on the Human Genome Project and the Saudi Genome, and how studying the gene could really in the future be on the hand of every physician to treat diseases. Thank you very much. My second speaker is Dr. Stephen Arnold. He's a full professor of bioscience, and he's the Associate Dean in Biological and Environmental Science and Engineering Department in King Abdullah University for Science and Technology. Dr. Arnold will talk about big data, but he will really focus on biotechnology and the individuals. What are the opportunities we're having in this field? What are the challenges in the future, and the future of healthcare in that field? Dr. Stephen, the floor is yours. You have also 7 to 10 minutes.
Thank you very much for your kind introduction. I'm grateful to be part of this interesting conversation. And I'm also, in KAUS, I'm also a member of the Computational Bioscience Research Center. And as such, I will highlight some of my key points using works from my colleagues, in particular Professor Takashi Kojibori, the director, Professor Shingao, the associate director, and as well Professors Zhang Chang and Robert Höndorf. But let me start with my own research. And this is in part, a good part in the field of structural biology, which we use to link with clinical data from our colleagues in the kingdom. And this linking of these two methods allows us to establish the molecular basis for genetic diseases, you can see here. And this in turn allows us to better understand the disease and to inform and personalize the treatment. Here, this is an example of a collaboration with Dr. Fawzan Al-Kuraya from the King Faisal Specialist Hospital and Research Center. But in the past 4 years or so, we have analyzed hundreds of variants from in the kingdom. And this pace would not be possible, without the availability of databases containing really big data, in particular the protein data bank, which contains more than 170,000 three-dimensional structures that have been determined experimentally. So our capacity for doing this work right now with this pace relies on agreements in terms of data format and data sharing made many decades ago. So the point here is that our need for big data entails the need for the openness and agreements of all players involved in bringing these data together. As the next example, I'll take work from a collaboration between the CBRC members, KAUST professors, and Andrei Ryseski from the University of Chicago. The team used AI on 150 million medical records from the USA to produce what they call a disease-agnostic polygenic risk score. So the particularity here is that instead of looking at a disease at a time, they combined all 600 diseases into a converted them into a multidimensional vector, and then they analyzed all of them simultaneously. With this approach, they managed to have to discover hundreds of new genetic associations, and they could also show, for a few cases, that they can predict future morbidities from the patient's genetic variation. Now, the importance here is that these medical records are coming from the US. So how can we be certain that this risk score is also valid for other countries and other regions? And of course, we cannot. Hence, the team teamed up, collaborates again with Dr. Fawzan Al-Kuraya to collect data on a local cohort to apply and optimize the polygenic risk score from the Western countries for the Saudi population. So here, my take-home message is that data-driven healthcare relies on a national scale commitment, but also it is important that each region produces their own data. Otherwise, one may be left out of the equation. Now, genes is, of course, not everything, and many diseases also include other factors, such as, for example, demographic or environmental components. And taking all these into account requires monitoring and linking diverse data. For example, measurements of air pollution, measurements coming from wearable devices, or clinical records, biomarkers, and so on. That's the work of Robert Höndorf from our center. And he and others are using the UK Biobank to apply this work. And this UK Biobank is a longitudinal study started in 2006 that combines or provides genetic, demographics, and exposure data of more than 500,000 citizens. So these are not patients; these are voluntary contributors. And using these data, they could show, among other things, that the exposure, the lifestyle, predicts the risk for type 2 diabetes twice as well as genetic or demographic factors. So the same also is true for certain cancers, and this really opens interesting opportunities. For example, because the genome, our genome, we cannot change it, at least not now, but the environment and the lifestyle, we can change it through policies and behavioral changes. So if you understand in detail how exposure and lifestyle involve or influence the risk of certain diseases, we can transform this understanding into actionable items. For example, do 30 minutes of sport of a particular type every day, and the diabetes risk will be lower, for example. And these actions, they could be monitored, for example, with wearable devices. Now, if they can be monitored, then can these actions also be sanctioned? For example, if someone does not do the prescribed 30 minutes of sport every day, would this person then need to pay a higher insurance fee? So there are lots of questions coming up which we haven't had in the past. So my point here is that the data-driven healthcare requires the engagement of individuals because they need to contribute the data, but it requires also the protection of these individuals. And for this, we need policy advances in parallel to the advances in innovation. Now, of course, we cannot talk about healthcare this year without talking about COVID-19. And indeed, for combating a pandemic that claims tens of thousands of lives every day, we need to have a rapid and open data sharing mechanism in place. And this has been acknowledged by the community, the scientific community, very early on. And the genomes of the virus, as well as scientific results, are now made routinely available on so-called preprint servers, where the data and the results are available immediately to everybody, as opposed to having a peer-reviewed subscription journals publishing these material only after, whatever, 6 to 12 months or even more. Now, with these new resources, we can do many things. For example, here a study by Professor Bocciobori and team, where they have this mutation tracker, which updates daily the COVID-19 viruses found in the kingdom and worldwide. It's interactive. Or a study by Professor Payne in Kaust and myself, which was tracking the clades of the virus in space and in time, and you can really see how one of these clades takes over in space and in time very rapidly worldwide. Now, there are lots of opportunities because this open science, not only for COVID-19, but also generally, allows to accelerate innovation, which is great. However, because we lack the peer-reviewed aspect of the science, there's no quality check of the research. And if some flawed studies are being picked up, for example, by the media, then these may affect the recommendations for the public and, more largely, also the reputation of science. So while open science provides us with new powers, it also gives more responsibilities to the individual to analyze these and carefully inspect these data. Now, another important or interesting aspect of big data is that we can also look at social media and use them as big data. Here's an analysis where Xianglang Zhang and colleagues used deep learning to analyze 105 million tweets between March and May. And in this way, they could detect the sort of the volume, the amount of tweets, and how hence the concern of the people of COVID-19. You can see in 5 languages how these curves are very similarly rising and then falling a little bit. But more than just the volume, you can also look at the emotions, the sentiments associated with these messages by picking up keywords. And here you can see how different sentiments represented by different colors change over time in this March to May time window. And here in this window where you can see the changes of this analysis, you can see how in the beginning of March, the sentiments were mostly anxious. And then we have a quite prominent spike of optimism and thankfulness, March 21st, 22nd, which coincides with the King's speech and with the taking of preventive measures in this period. So it's quite astonishing. With this analysis, you can provide policymakers with a direct measure of their actions, repercussions on the people. Of course, this comes with a lot of challenges. For example, the natural language processing still needs to be improved in non-English languages to avoid that some messages are misinterpreted. And of course, the big question also is if social media is a good measure. I, for myself, for example, I'm not using Twitter, so my opinion would not be represented in here. So while this social media assessment provides local direct feedback, it also shows the need for analytic developments, local developments, and of course a good questioning about what is the choice of the right measure. So in my last example, I will go through an analysis carried out by Professor Gao and his team, where they used AI-based segmentation and quantification of CT scans of lungs from COVID-19 patients. And they could show that their methodology improves the quantification and of infected volumes of these lungs, and this in turn allows better disease monitoring and treatment. Now, for me, the really spectacular aspect here is that this team produced this methodology or this algorithm only during COVID-19 this year, and it's already deployed by King Faisal Specialist Hospital and Research Center radiologists, which really witnesses the great collaboration, the great engagement that both the scientists and the healthcare practitioners had in this respect. And currently the teams go one step further and provide what they call an AI-augmented vessel-removed CT scan. It looks like this, where they can now reveal, which wasn't possible previously, that COVID-19 patients have sustained damage to lungs even months after their apparent recovery.
You have 1 minute, Dr. Arnold.
Thank you very much. And I will use this to conclude. So here, the important part is that applying AI technology requires the engagement and the collaboration of healthcare practitioners and scientists. And if that's carried out in the right way, then of course AI will not replace physicians, but physicians who use AI will replace those who don't. And I think I can just put up my conclusions, but I think it's just what I just said. Thank you very much.
Great. Thank you very much, Professor Arnold. I think Professor Arnold took us to a second stage. Do you hear me? Yeah?
Sorry?
Okay.
Yes.
Thank you, Dr. Arnold. I think, he's specialized on linking and sharing data. It's very important and example of COVID-19 and how this, sharing and linking data with other diseases can really help in answering a lot of questions. That will bring me, because of time restraint we have, that will bring me to the third speaker, Dr. Omar Al-Ubaid. He is a consultant, he's a clinician and associate professor of surgery. He is specialized in bariatric surgery and endoscopic surgery, and he's also the chairman of Department of Surgery in King Saud University in Riyadh. Dr. Omar is going to take us further in technology and health and take us really inside the human body. And tell us more about the use of technologies in surgeries, and he's going to talk about the use of robotic in surgery. So the floor is yours, Dr. Omar, and you have about 7 to 10 minutes, the same like your colleagues. Go ahead.
Thank you very much for the invitation, and thank you for the introduction. As you have mentioned, Dr. Maha, I'm going to speak about the future of robotic surgery. Is my presentation, you can see it or no?
I can't see it.
Okay.
No, now
okay.
We can see it. Go ahead.
You can, yeah, okay. So the robot is not a new idea. The first time people started talking about robots was in 1770 with the famous Turk chess. And in fact, this was not a true robot. If you look inside the box, there was this little man who was holding the mirror and with a stick moving all the players. The definition of robot when it was started in the 1990s in the surgical field was defined as a surgical robot has been defined as a computer-controlled manipulator with artificial sensing that can be reprogrammed to move position and position tools to carry out a range of surgical tasks or movement. The new definition of robot is completely different. It's an information system with eyes, legs, and hands. If we look at the journey of the robot starting from 1985 till the fancy machine in 2000 and actually 1998 and 2000, then we started getting in the last 2-3 years more fancy machines and multitask robots. This is a quick simulation movie to show you exactly what's happening in robotic surgery. In 1998, the first robotic surgery on a human was done. Then in 2001, and exactly on the 7th of September in 2001, the first transatlantic robotic operation was done by Professor Marisco. He was sitting in New York, and he operated on a patient in France, in Strasbourg. However, this did not fly, I think, because of the lack of the medical technology. There were some other surgeries, but very few. You can count in one hand. And at the end of my speech, I will highlight why we are late in medicine compared with the technology. However, the advantages of the robot, I can summarize it in 3 things. First of all, the 3-dimensional visualization as opposed to laparoscopic surgery when we see only 2D view. It eliminates the tremor, and it gives a good scale of surgical action. Now, you can reduce your scale of action from 5 to 10 centimeters down to 1 centimeter. Also, you can have the advantage of 360-degree rotation with the robotic arm, which we cannot do as a human. However, the technology is expensive. The training is not up to the expectation, and it used to take a bit of time to prepare the robot, or what we call it, the docking time for the robot. The technology right now is, we have it on hand. As you can see on the screen, this is the surgeon sitting on the console of the robot, and he is moving the robot with the assistance of the nurse and his surgical team. What we are planning or what we are expecting to have in the future, a more delicate robot that can be done without any human assistance. Currently, we have robots for every part of the body. We have a robot for the hair, for the spine, for the joints, for the blood vessels, name it. We have many robotic machines. It comes from over 88 companies around the world, from 16 countries around the world. What is pushing or forcing the robot into the market? A couple of things. Number one is the safety, the improved economic position for the countries that are producing the robot, the efficiency, the accuracy, lots of positive forces. However, the negative forces are also there, mainly the cost of the machine, cost of the instrument, and again, the training and the marketing. Out of those couple robots around the world, I was interested with one that I will present here is the CyberKnife machine. If you look at the CyberKnife machine, they were able to take the helmet from the tip of the machine and replace it with a proton beam that can send the radiation, and through another robotic arm, which is the bed where the patient is sitting, you feed all the information into that bed, and the information with the two robotic arms, the CyberKnife and the bed, you can send those radiation to a very specific area and kill the tumor with a margin of only 3 to 5 millimeters. This is probably more accurate than what we can do as a human. Now, we are hoping in the future that the technology company, the soft side of robots, that will be able to improve it more and more, like the Google Pay, probably will have in the future the an app that you can download and you can play your robot with. Potential players, actually some of them, they are now in the market, like Google. They are going to produce in 2023 in combination with the J&J their new robotic machine. For more future direction, we are hoping for integration of preoperative image and intraoperative video to guide surgeon dissection and more precise, localized resection of a disease part. We are also hoping for combination with virtual reality simulators that could also allow the rehearsal of complex procedures before we do the operation. Now, again, what's going to happen in the robotic surgery in the future phase, based on the trajectory of what's happening right now in robotic surgery, it's that we are hoping that we will be able to do the preoperative imaging and the image based or image guided surgery for that you feed those information into the robotic machine, and then the robotic machine will be able to do that without any human in the operating room. All of this will happen with the, again, with the intraoperative navigation, with the simulation, preoperative surgical warm-up, and more training. Also, and some of those are already in the market right now. We are having a more sophisticated robotic machine as a small pill that you can swallow right now and take images for the whole gastrointestinal tract. Those capsules now are already manufactured, but they are improving them so that you control them with a remote control from outside. They have those little wings that you can move them around and will be diagnostic and therapeutic in the future. Also, we are looking for the multi-finger instrument. We are looking also into an instrument that will carry on again what we call the natural orifice operation or surgery knots. Those operations use the mouth or through the vagina in a woman without any scar in the abdomen, that you can go and remove diseased organ. The only limiting factor for, although those surgeries were done in the past, but the limiting factor was the availability of the technology. However, now we have this technology where you have the machines with multi-pores that you can use 3-4 instruments at the same time through a single channel endoscopy. Again, those, as actually my son called them as the Swiss knife. They have multi-tasks. Future also planning is to have no people operating room. You have the surgeon sitting in the console. You have the directing the robotic surgeon with a scrub nurse and a circulating nurse. Now, with laparoscopic surgery, this is the first time we operate without looking into the patient. We touch the patient through an instrument, but we are looking at the screen. With the robotic surgery right now, we operate without looking and without touching. Probably even we are not present at the same place. This is all you think probably is not going to happen, but in fact, it already happened in the research lab. You think this is an imaginary photo, but if you look at this one here, yes, this is exactly what's happening. I'm going to just run this video very quickly. You have the smart bed with the information of the patient all inside. This is the scrub nurse. This is a dispensary or like a dispensary pharmacy working as a circulating nurse that will give the instrument to the scrub nurse, which will give it to the surgeon. The time that's used to do the whole procedure is 11 to 17 seconds only, with an accuracy rate of 99.97%. This is for sure more than human. Again, we are looking also, Dr. Nadeeh was talking about the genetics. Now we are hoping that we will have the genetic surgeons. We moved from the regular Doppler or ultrasound machine to the high intensity focused ultrasound. When this yellow light light up, it means that you have coagulated the middle of this bovine lens without any damage to the surrounding structure. Even with the femtosecond laser, when you push the button with a high speed, it will give you the femtosecond laser. With the femtosecond laser, you can shine it on a cell, and it will open the wall of the cell, and you can go and operate inside the cell. You operate on the chromosomes, you operate on the nucleus, Golgi apparatus, and so on. Again, with the nanotechnology.
You have 1 minute to wrap up if you can.
Okay, sure. I will. With the advancement in nanotechnology, we will hear about the genetic surgeon again, and we will operate inside the cell. And this will take me to quickly what we call a preventive surgery, that we can go inside the cell and repair the problem before the appearance of the disease or the symptoms of the disease. All what we need is just to match up as a healthcare with the technology and business, try to solve all the financial limitations, and we will be there, inshallah, very soon. Probably you will say this guy is crazy, but you never know. In 20, 30 years from now, you will have the robot coming to your home and do the operation. Thank you very much.
Thank you very much, Dr. Omar, for this really exciting and eye-opener lectures about the future of surgery. It's really clearly that there is a lot of new players in the medical fields other than doctors and nurses. And I hope in the future that we still need doctors, and robot is not really taking over the field. But it's really good to hear this and to know where we're going in the future. It is not, it used to be a dream, but now it is really a reality. For the sake of time, also, I will go right away to my fourth speaker. It is Mr. Abdelkader Al-Mu'in. He's the head of the health section, and he's a consultant in artificial intelligence at the National Center for AI, the artificial intelligence, which is, I think, part of the Saudi Authority for Data and Artificial Intelligence. Dr. Abdelkader Al-Mu'in, he will speak about artificial intelligence to improve our future. In general, what are the quality, and to improve our future and quality of life. And he will shed light on the application in health sector. The floor is yours, Dr. Abdelkader Al-Mu'in, and you have also 10 minutes.
First of all, thank you for inviting me to be part of this great forum, and it's be an honor to be part of the great panelists. So as I think my colleague stated, how the future, in particular in the healthcare, and how AI and big data and robotics is changing the way we think of health and how we deliver the healthcare as a sector. So just in my presentation, I'll shed the light on what is AI in health and how we define AI in health, and actually why healthcare or in health in general is a hot topic and a domain for the artificial intelligence, and what's the future of health, and what our main concern and benefits that we think AI can drive or help within the AI agenda. So eventually AI or artificial intelligence in the healthcare is pretty much using complex algorithm and software. In another way, it's pretty much we're trying to emulate how humans think and do things in a cognitive way, where they can analyze and interpret things and do it in a comprehensive way. Healthcare being selected one of the top priorities, in particular in the kingdom, and I think across the world, for different reasons. If we look at the Vision 2030 and why our 96 strategic objective, there was 3 key themes where we are looking for a vibrant society, thriving economy, and ambitious nation. And out of those 96, more than 67 is around data and big data and AI. And 3 of those actually being directed linked with the healthcare sector. And the challenge of the healthcare is almost replicated in every nation and every country across the globe. So we all struggle with the ease of access to healthcare due to different reasons. I think we always have a limitation when it's come to access to care, especially in geographic and different availability and the fund. Also, one of the biggest challenges as well is how we improve the quality of care. Today, we double spending compared to our GDP in the healthcare, but if we measure it quantitatively to the percentage improvement on the healthcare as a service, it doesn't reflect that much. And this is a big challenge because we cannot just continue spending more money and expecting the service or the quality will change. We want to shift from being treatment toward more prevention, and how we can leverage big data and AI to improve the prevention side of medicine. In particular, when we combine many sources of data, like my colleague stated, genomics, bioinformatics, and consumer informatics as well. As those 3 priorities evolve in the kingdom, we identify some of the potential use cases that we want to leverage using an AI. As a National Center for Artificial Intelligence, we are building the whole ecosystem, because as we stated, without collaboration and open innovation, we cannot move forward. With that, we identify some of those use cases, and we can go through some of those. I think with the COVID-19, many of healthcare system collapsed or failed due to some of the issue related to the capacity planning. Today, AI and artificial intelligence is a big player and an enabler to help the health system to plan and at least allocate the right resources at the right time to the right target. We leverage virtual consultation, and we can embed it in AI to improve and facilitate triaging, where patients or the public can just go and chat with their phone to be triaged and to some extent refer to the right physicians. We always look at the healthcare as from a clinical perspective. However, there are also so many non-clinical activities that's happening within the health system. If we look at the time spent by nurses for documentations is more than 40% in the ICU. And the same for the physician who are doing a lot of documentations. Now, AI and artificial intelligence can support in many non-clinical activities, which to some extent maybe much faster can be implemented within the health sector. Also, to improve the value of healthcare, we can look at AI-powered diagnostic tools and using big data to help physicians to do the right diagnosis to the right patients. The same, we talk about surgical robotics and how AI can enable this and make them more smart and more precise. I think when it's come to the experience of how we can leverage AI in particular for vision computing and medical imaging diagnosis using an AI with the highest accuracy and a better detections to specific diseases. As we stated, we think always that the health system has answer to all our problems, but unfortunately, that's not the case. Today, if we look at the amount of data that physicians is dealing with, or they make their judgment or decision, doesn't represent more than 15% in good cases, sometimes even less. The majority of the data actually is outside the border of the health system. And that's why we want to bring to the equation genomics and the lifestyle and the consumer informatics and those type of data outside the border, and trying to help strengthen the prevention equation. How we envision from a national perspective and how we want to enable a full ecosystem where we want to bring researcher at the genomic and bioinformatics world, and bringing the data from clinical and health informatics, where the data today within solo in each hospital or each system or health system. And eventually, as we all know, Apple and Google might know about the public and their lifestyle better than anyone, where they have a lot of data capture from the public and the consumer informatics. And if we bring all those together to our researcher and scientists and physicians and clinicians, and using big data and artificial intelligence as an enabler to support solving many of the problems today, the healthcare been struggling for the past 40 or 30 years to solve, I think we can find an answer. With that, we want to develop national initiatives with a program of excellence, leveraging AI as a technology, as an enabler, as a solutions. And I think it would never replace physicians. It will augment and empower physicians. Just for the time, I'll just mention one example where in China, a physician or a family physician, they do per day, or they see per day, almost 7,000 patients, and they diagnose them, they write prescription, and they follow up. And when we visit the center, we find that actually the physician being augmented with AI support clinician who is actually doing the review for the clinicians, putting the recommendations, following up with the patient in an electronic matter, and eventually the physician will just review, make sure that the plan, the diagnosis plan or the diagnostic is correct, the plan is correct, the medication is fine, and then they will just approve and accept. With the greatness of the technology and AI, there are a lot of concern. And I think this is one of the tackle or the issues that in a national level we want to overcome and solve, in particular for AI. AI is a very powerful tool, but we have a couple of concerns, in particular in the healthcare sector. We want to have a responsible AI because, as I said, it can be used for the good and it can be used for the bad. At the same time, we want it to be unbiased, and we want to ensure that with the algorithm development, how we ensure equitability of any algorithm and with no bias to ensure that everyone with no differentiation when it's come to the race or the gender or the religion, etc. Traceability. And I think
دكتور معين لو معلش في I think the second session will start now. Can you wrap up? You have a couple minutes maximum, 2 minutes.
Yeah, just a couple of seconds. Traceability, and I think this is what in healthcare is the challenge for the AI, because we have to explain why the AI is making the decision, because there is a legal liability and responsibility. We want a reliable system. If we go with AI in a surgery, we're not expecting the system will make, we want to ensure it's reliable. And at the same time, on top of all of that, we want governance to ensure that we have a governed AI at the national level where it supports the industry and support the clinicians. With that, I'll just close my talk, and eventually the Saudi is embarking on in the data and AI to becoming one of the top 15 nation globally in 2030. And we already launched the national strategy for data and AI in the summit. And today we activated the sector of healthcare and energy as a top priority for the kingdom. And I'm inviting everyone to visit the website and see the national strategy. And with that, thank you very much.
Great talk, Dr. Abdul Qadir Ma'in. Thank you very much. I think at the end of this session, I think we have really shed light on the vital role of technology and artificial intelligence in the healthcare, and maybe from this place, we call on to the government to really improve the infrastructure that needed to improve the link between the technology and the healthcare. Because of the time, I was unable to. I have prepared some question to you, but I was unable to ask because of time. But that will give me pleasure to thank you all for great talk that you really shed light on this vital and critical issues of health and technology. And thank you all for your time and for your presence in this session. And thank you very much and goodbye.